Hi, this is Elliot Fishman, and welcome to our latest Facebook Live. Today is Thursday, November 19th, 2020. I hope everyone's doing well and being safe. I know the news about the numbers is terrible, but the number you have to focus on is the 95% success by Pfizer and nearly 95% with Moderna. I think it's just a matter of now time. I would bet that within a week, the Pfizer vaccine will be approved by the FDA. I know there are certain risks in theory just because we haven't followed it for a couple of years, but I think everything looks really good. The safety profiles are wonderful. It's not a live virus, so I think 95% is as good as it gets. We were hoping for 70% as a miracle. Remember, the routine flu vaccine is 40 to 50%. The measles vaccine is 93%, and you don't worry about measles. So 95%. So we just got to make it through the last mile. That's going to be really critical because you can see the numbers are going up everywhere. New York City just closed down their schools. Mayo Clinic reported 900 of their employees with COVID. So it's really a problem. So all I could tell you is you just need to be careful. There's no real magic in that regard of what you can do. I have my purple shirt on, and if you can see, it's not for the Ravens, it's for Lustgarten Foundation. Let me stand if I can. Let me see if I can move my camera so you can see it. There's my Lustgarten shirt. And Lustgarten is a foundation that supports pancreatic research. Lustgarten are the folks, they're out of New York, who are very generous supporting our research. All of our AI, the last 4 years, is supported by the Lustgarten Foundation. And we really take it extremely seriously, their support and how important it is to us. And we are very much working hard to try to find a way for earlier detection of pancreatic cancer using AI. Not only did we roughly have finished 4 years of work, and last night, Alan Yulee and I, representing the team, presented to the Lustgarten Foundation about what we've done over the past year specifically, but really the past 4 years, and then carry and looking forward, hopefully, to get funding for the fifth year. So hopefully we were successful. I think we've done a great job. COVID has hurt a little bit in terms of hiring additional people, but everyone's been able to work from home, which has been really good. So our numbers have been strong and our research is really strong. So I think that becomes very, very, very important to us. I see John Biacchino's at home, and let's win pancreatic cancer. We do love some Baltimore Ravens. Okay. But yeah, the Ravens have purple. Okay, but the most important battle is not the Ravens. The most important battle is on cancer. So I thought I would share with you a little bit of what's happening in terms of pancreatic cancer, both of what we're doing, but more in the global perspective. And what you are seeing is from a medical oncology, there is no magic drug. Alex Trebek, who just passed away, unfortunately, from pancreatic cancer, was some new therapies. We have some new therapies. There are a number of trials going on. But I will admit at the current time, there really is no magic bullet. It's not like lymphoma or a GIST tumor. We don't quite have that magic bullet yet, though it's not for lack of trying or vaccines. One thing I look forward to from Moderna and Pfizer is because they've learned so much about mRNA, it's very possible that that could help you develop vaccines for cancer, and that would be ideal. This has been a miserable year, and it's going to be miserable for another half the year to a year. But if we can get something out of it, like with this whole vaccine technology, perhaps, remember, vaccines are the way to go. What if you could develop a vaccine to protect against cancer? It'd be unbelievable. Or pancreatic cancer, unbelievable. So let's not rush ahead, but that's some of the things you'll be reading about, I think, over the coming year or two. I think one of the things in terms of pancreatic cancer, the surgeons and previously we used to think that surgery was the cure, and surgery is still the only way of curing pancreatic cancer, but it's rare now for someone to go straight to surgery. Most of the time, patients are getting chemotherapy or radiation therapy to kind of kill the tumor and then operate. So we've learned a lot about what the best way of managing patients are. Our surgical skills have gotten better. The length of time patients are in hospitals from Whipple's procedure or distal pancreatectomies, the complication rates are much lower. And a lot is being done by robotic. There's now a trial going on. Hopkins is one of the main participants, comparing robotic surgery for Whipple's versus standard. And it seems robotic has a lot of advantages, as it does with many operations, not so much the surgical time, but the recovery time. So hopefully that will continue. So we're going to see about that. So that's something that's new in pancreatic cancer. Now, in terms of detection, we're radiologists, technologists, so we're really on the detection side. The issue we have found that others have found, and it's been well published and publicized, is up to 30% of cases of pancreatic cancer, you could pick them up on a scan before the actual scan where it's detected is done. What that means is, if a patient presents today with a pancreatic cancer and you diagnose it, even you pick up a small lesion, 18 millimeter lesion, 2 centimeter lesion, oh, it's small. Invariably, a lot of those patients had a scan 4 months ago, 6 months ago, 8 months ago, and the tumor was present then. You didn't see it. It was small, and in retrospect, you can see it. That's really where we're aiming our AI. Not that you know, it'd be wonderful if you could see something that even in retrospect I don't see. That would be incredible. But find at least the stuff that I would find in retrospect. That becomes very important. And particularly smaller cancers, those are the ones you're going to miss because you try not to overcall. You can't read every pancreas says slight irregularity, advise clinical correlation, advise follow-up. You don't do that. And so you miss that opportunity for picking up small lesions. But it's a challenge balancing the overcalling with the undercalling. We have the same issues with AI. How do you balance calling something when it's early versus someone overcalling the presence of disease? That's a challenge. But the fact that we know that patients have tumors that are potentially resectable, unfortunately, that a lot of those patients, remember, only about 15% of patients at time of presentation are potentially resectable. 30% of them, 30% more would have been resectable if they were picked up early. So our goal with AI is, can we even pick up half of those patients? Can we pick up things where you look at the study and say, damn, I wish I would have called that, or other person should have called it, or geez, in retrospect, it's there. Those are the ones we need to pick up. That will make a massive difference. That'll save 10,000 lives a year in the US alone when you do some of the calculations of 55,000 people newly diagnosed every year with pancreatic cancer, and the number is increasing. So we're focusing our AI on that. Our results now are really spectacular. So one of the things we've done over the last couple of years as well, not only, although our funding is for pancreatic adenocarcinoma, in order to really develop the algorithms correctly, you have to understand CIS, you have to understand neuroendocrine tumors. And so we've developed new algorithms for neuroendocrine tumors because they are different. They're typically vascular, and adeno is hypovascular. We've also developed new algorithms for CIS detection. It's hard to get small tumors. It's easy to get small cysts. So we have a better than 90% accuracy for picking up cysts that are 2 or 3 millimeters in size, it seems. Now, one can say that's a good and bad thing because you're using cysts as a marker for cancer, which can be problematic and may be the wrong thing to do. But on the other hand, if we can't find cysts, we won't be able to find small tumors. So that's one argument. And the other argument is that we need to train the computer to find things that look abnormal and then have the radiologist step in and make the decision whether or not it becomes important. So that really is a major, major feature of what we're doing now. We also have been very successful in comparing the computer to radiologists. When you compare adenocarcinoma, the computer, meaning AI, deep learning with radiomics, versus the best radiologist, the computer is more than 15% more accurate. When you compare autoimmune pancreatitis versus cancer, computer versus expert radiologist, the computer is 25% more accurate. When you're looking for small neuroendocrine tumors, those under 2 centimeters, comparing the computer versus expert radiologist, the computer is probably 20% better. So we are really looking at a 15 to 20% gain just by using the computer. So now what we need to do for this 5th year is take it from that research phase to bring it into practice. It needs to be used at Hopkins, it needs to be used at other institutions. So we need to manage the product so that it becomes more user-friendly. Right now, the computer people can run the algorithms. It doesn't have a simple user interface. for AI to work, it needs to be in clinical practice. You need to have radiologists use it. You need to be in a situation where it's not just Hopkins, but it's Mass General, or it's Baltimore Community Hospital. You name a hospital, I just invented that Baltimore Community Hospital. But you need to be able to have everyone use the system and then to test it. We do have a survey, actually. If you have some time, if you go to Facebook from CTisus, you're on Facebook Live now, but pinned to the top of our Facebook page is a survey Linda Chu put together, which looks at what radiologists think about AI, what they're willing to look at. So if I said to you, every time you look at a pancreas, half the time I say there's an abnormality present, you're probably not going to use our software. The question is, how many errors would you be willing to put up with? If I picked up one cancer extra and I called 10 maybes, would that be okay by you? Or do I only need to pick up the one cancer and be perfectly accurate? Now that, of course, is kind of almost impossible. But if you're not going to use it, the AI product we develop or anyone develops, that becomes an issue. So a lot of the AI thing we're learning is what people are willing to put up with, because if the computer is automatically telling you to look at something, you're going to be forced to look at it, and then you may get into that hedging. Well, is it real or not? Do you believe the computer over yourself? What do you do? I think that's going to be something that's going to be a challenge and something we need to learn from. In the comments section, let me also say hi to Lydiana. Lydiana is out in Palo Alto, California, good friend. And Lydiana's dog Waldo had some surgery yesterday, so hopefully Waldo is recuperating well. So we wish Waldo our best. And as they say in Hebrew, refuah shalema, for a quick and rapid recovery. I see Lily, who's listening to my talk back in Baltimore, actually put the link up. So if you look at the comments section, you'll see the link to our survey. At this point, we're only surveying radiologists. I think we will probably, after we finish this, come back and survey technologists to see what they think. We'll modify the questions a little bit, but it'll be interesting to hear what technologists think and how technologists think differently than doctors, or maybe they don't think differently than doctors. It's also interesting with CTisus doing a survey, anyone in the world can answer. On Facebook, more than 80% of Facebook users on all sites are worldwide. They're non-US users. Only about 17 or 18% of Facebook people are actually in the US. Remember, Facebook has 1.5 billion people log on every day. The US has about 350 million people. So unless a lot of 2-year-olds are logging on, it's a big world out there. So it'll be interesting to see. One of our questions is what country you're from or what continent. So it'll be interesting to see if people in New Zealand think differently than people in Australia. Probably not, but they may think differently than people in Africa or North America or South America. So it'll be interesting to look at many of those bits of information. So that becomes very, very important to us. Now, other things in terms of pancreatic cancer, I think the biggest thing really to be careful about, I mentioned this before in some of our lectures, when you're reading pancreatic studies, if you see a duct transition but no mass, you got to be worrying. You could do an MR, you could do EUS. An abrupt duct cutoff, even with no mass, you have to worry. Sometimes the mass is small, it could even be a neuroendocrine tumor, but also you can have an isoattenuating mass. Typically, to me, it's well under 5%. Some articles say 10%. But you have an abrupt cutoff, there's always a tumor there. Dr. Cameron would operate on abrupt cutoff duct. He's not going to need pathology. Now, is it possible to have an abrupt duct cutoff? I guess if you had trauma way back when, maybe, or a stricture from inflammatory, but if you don't have a history of anything, and there's no signs of pancreatitis, you have a duct cutoff, to me, you have a cancer. And yes, once in a while it's neuroendocrine, but most of the time it's an adenocarcinoma. That becomes very important. Other things that are commonly missed are subtle tumors, particularly off the uncinate process. I was looking at a case recently where that was the case. We picked up a small tumor, but in retrospect, going back 6 months, there was a lesion that was under a centimeter, maybe 8 millimeters in the uncinate process. And if you go back to a scan 5 years before that, there was nothing there. It's very subtle. And yes, you can say, would I ever call that? I don't think so. But looking at the old scan, looking at the new scan, perhaps I should have called it. This is where I think AI is going to be big in picking up those small lesions, because I think AI is going to also do a good job of comparing old and new studies. Has the pancreas changed, and is there something significantly different? Now, it's interesting, we have not been working on new versus old studies with pancreatic cancer. We treat every study individually, so we have looked and could you pick up cancers earlier in a patient who has cancer today and had normal scans before? That's a little bit different. And I never really thought of it, but you know, as radiologists, the way we often pick up pathology is something very subtle, but it wasn't there before. I was reading a case of ovarian cancer, an outside case, yesterday, and you were able to see something, and it's interesting that you're able to see that. So it comes out very, very nice. I see Ava Zinreich is FaceTiming me, but I'm sure that probably was a mistake. So I'm not going to accept it. But I think that one of the things is really, you know, how can we improve those subtle lesions? And I think that's really where, if you look at the Felix Project, where we're going for the next year, we're going to really try hard and working. And one of the things we need to do, and the Lustgarten is going to help us, is get from multiple institutions small tumors. I think that becomes very, very, very important to us. So I think we're looking forward to that. And I think that's really going to challenge us with our algorithms. So I think that indeed becomes very important. Let's see, what else can I tell you about pancreatic cancer? Protocols, again, CT is the way to go. There's other work going on. People are looking at, I was at a Kenner Family Foundation. People were speaking about how looking at muscle mass can help predict patients with high risk of pancreatic cancer by decreasing muscle mass. Also, the talk about diabetes, someone with new onset diabetes with no good explanation. It's not uncommon for them 2 or 3 years later to develop pancreatic cancer. So there's some studies going on. Mayo Clinic is one of the big studies. How carefully should we watch people with new onset diabetes? Are they super high risk for pancreatic cancer, and should we be screening them? So that indeed becomes very important. So how we do things is going to change. We're looking more at risk factors. We're looking more at outcomes. We're looking at how we could do things better, how we could pick up cancer early. There's no sense picking up a mass if you can't improve survival. There's no sense, you know, putting a lot of effort in. We got to put the effort where we can get bang for our buck. And that becomes very critical. So going back again to the Lustgarten Foundation, going back to Stand Up for Cancer, but especially Lustgarten, going back to any of the wonderful groups that support pancreatic cancer research. Today is Pancreatic Cancer Day, so it's very, very important. Normally we would have walks and marches and all sorts of really cool things. You can't do it these days because we have to be safe. So we look forward to maybe in late 2021 having a Lustgarten walk, which we did last year, where I got this super cool t-shirt. And I think that's it. So if anyone has any questions, now is a super good time to ask them, and I'll try to answer them. So as Thanksgiving comes ahead, you know, next week, I just want to tell people, you should remember, don't go away for Thanksgiving. Don't have people come over who are unsafe. Wait till next year. Have 2 pieces of turkey next year, or just eat turkey this year. Eat it by yourself. You'll have more leftovers. Buy a smaller turkey. We are celebrating here. We bought a breast and two drumsticks. It's not quite a turkey, like a whole turkey, but it's very efficient. The drumsticks make me think of Disneyland, right? They sell drumsticks at Disneyland. I don't buy them because they're not kosher, but these giant drumsticks. Looks like something out of the Flintstones. But whatever you do, be careful. You don't want to risk things. It's getting colder out here. It's in the 30s today. As people come inside, everything gets a little bit more challenging. Don't be eating with other people. Don't be going into break rooms where people are eating without masks. You got to be careful. So with that, I thank everybody for their attention. And we'll be posting a lot of good stuff on Pancreas today and over the coming weeks. And we'll see you then. Bye-bye.